A myocardial infarction is a sudden, violent failure of the body's primary engine. When that muscle begins to suffocate, the brain often registers the signal as a burning ache shooting down the left arm. Cardiology textbooks describe this specific pathway, pain traveling down the inner left arm to the little finger, as a hallmark sign of a heart attack. While clinical practice recognizes the symptom, biomedical models lack a specific mechanistic reason for why the alarm rings in the little finger rather than the thumb or the index finger. Traditional Chinese medicine mapped this exact anatomical route millennia ago, treating it not as a secondary effect, but as a predictive diagnostic tool. The TCM map illustrates the heart meridian. It runs from the chest, down the arm's ulnar side, terminating at node HT9 on the little finger. Despite different origins, both systems isolated the identical physical pathway between the heart and the fifth digit. Comparing why both systems point to the same digit suggests a method for recognizing cardiac distress before structural damage is evident. The Western biomedical model traces this symptom back to ischemia. A coronary artery becomes blocked, starving the heart muscle of oxygen. The ache in the arm is classified as referred pain. It occurs because of how the nervous system is organized into sections called dermatomes. The C8 and T1 nerve roots innervate both the heart and the ulnar side of the arm. In the brain's sensory mapping, these two regions share the same circuitry. When the blocked heart muscle sends distress signals to the spine, the brain can misinterpret the origin, registering pain in the shared nerve pathway in the arm and finger. This sensory alarm is triggered after physical ischemic damage has already occurred in the heart tissue. Clinicians are trained to take radiating little finger pain seriously, even if structural tests like ECGs show no immediate abnormalities. The dermatome map identifies the wiring of the symptom, but it requires a physical breakdown for the signal to activate. Traditional Chinese medicine views the heart as both a mechanical pump and the residence of the Shen. In this system architecture diagram, the Shen acts as the command center, the pilot regulating the body's survival instincts and consciousness. The pericardium functions as the interface, acting as a buffer that protects the heart muscle from physiological and emotional stressors. In the Shen Qi-Ji model, Qi is a bioinformational current flowing through predefined meridians. High emotional stress or psychological trauma strikes the pericardial buffer first, gradually eroding its capacity to shield the heart. When the pericardium is overloaded, the informational current along the heart meridian becomes jagged. This upstream turbulence moves through the channel, manifesting as pain, heat, or numbness at the HT9 node on the little finger. This informational turbulence occurs on the meridian timeline before structural ischemia damages the heart muscle. Within the Shen Jing Qi framework, little finger pain is a primary predictive warning sign of systemic overload. Modern cardiology operates within a diagnostic window that begins with the arrival of structural failure. Standard tools like ECGs and enzyme tests target the markers of this failure. These tests are calibrated for tissues that have already begun to break down, leaving pre-ischemic informational strain unrecorded. Consider this clinical timeline of a 53-year-old male who presented with intermittent numbness in his left little finger during periods of high emotional stress. During his early visits, his ECGs were normal. On the structural track, there was no measurable evidence of distress. The energetic track, however, showed a significant spike. A TCM assessment identified the pericardial strain and Shen disturbance corresponding with the numbness in his Inger. Weekly acupoint therapies at PC6, HT7, and KD3 were used to regulate the informational flow. The numbness resolved and his markers of Shen stability improved. 3 years later, a routine scan identified a minor coronary blockage. Because the patient had been monitored and treated for the earlier informational warning, he avoided a major cardiac event. Clinicians can apply this by palpating the heart meridian from HT7 to HT9. This provides a way to screen high cortisol patients for temperature or stiffness anomalies before they reach the threshold of structural failure. This case demonstrates how the anatomical wiring recognized by Western medicine and the informational signaling of TCM can be used in tandem to identify cardiac risk long before the heart breaks.